Welcome to Ask Dr. Barken, brought to you live every Tuesday evening at 6 p.m. Pacific Time. Ask Dr. Barken is a free service of the Prostate Cancer Research and Education Foundation. To ask your question about prostate cancer or any men's health issue, please press number 9 on your touch-tone phone. And now, here's Dr. Israel Barken.
Hello, Dr. Barken.
Hello, Dr. Dugban. It's so nice to hear your voice. I want to tell all our listeners that we are very fortunate. We are going to have Dr. Dugban giving us a lecture on Ask Dr. Barken call-in show. And at the same time, we are viewing a PowerPoint presentation. So, Dr. Dugban, carry on.
Thank you very much, Dr. Barken, inviting me back. It is my pleasure. This afternoon, my topic of this lecture would be power Doppler transrectal ultrasound for prostate cancer detection, characterization, staging biopsy, and future development. When we start doing prostate ultrasound, we have to have a clear-cut idea what we are looking for. First, based on ultrasound image, we can precisely determine the gland volume by measuring the width of the prostate, height of the prostate, and the length of the prostate, multiplying all those three numbers, and dividing half would be your prostate gland volume. After that, based on the gland volume, we could predict what is going to be your PSA. That is simply 10% of your gland volume. For example, if your gland volume becomes 40 cc's, your predicted PSA should be 4. If it is 80, it would be 8. So that means if you have a larger prostate gland, you could have a higher predicted PSAs. Then we have to compare this predicted PSA with your actual blood-drawn serum PSA. If your blood PSA is higher than our prediction, then you have excess PSA, too much of PSA. Then we know that 1 gram of cancer approximately excretes 2 nanograms of PSA. So dividing by 2 could be your expected tumor volume if we have any. Then we look for the area size of the cancerous area in the prostate. And on top of that, we got to know some anatomy. In case cancer going to spread out, where it's going to follow, how it's going to follow and to get out. Mainly through the neurovascular bundle. I'm going to show this one as a picture. Seminal vesicle towards the apex. This diagram shows that your prostate, as you see, by looking at my cursor around, dark spot is a cancer. This is the so-called neurovascular bundle, nerve and vessel bundle coming in and out. It's the anatomy. Everybody has it. When cancer want to come out, it usually follows the neurovascular bundle. Or the side view show that the bladder, urethra, and become a penile urethra. If cancer is in the apex, that means the distal tip of the prostate, it can easily get out through the neurovascular bundle. If it is in the near the base, this top spot, cancer might spread out to the seminal vesicle. Most importantly, we got to know how close your cancer in the apex is to the external sphincter. If cancer is extremely close to the external sphincter, it will be problematic in terms of the cryosurgery, even radical surgery, because of the we don't want to damage the external sphincter. In that case, you may end up with urinary incontinence. So if you see some lesion like that, you got to take a biopsy. Should be a mainly target biopsy. Random biopsy might miss the cancer, as you see here. That we don't want to have that. And if cancer is so-called within the inner gland, these are the areas of cancer spread early on towards the bladder neck, towards the apex. I'm going to show some diagram, show that this is the inner gland, this bluish area. Cancer is there, break through that corner, or comes out towards the apex or towards the bladder neck, and the biopsy should be precise. That means if someone put a needle in here about this level in the rectum and fires, then it might not reach the lesion. It's too far away. That's why it is important to identify where is the cancer, and we have to push the needle in all the way and then fire, otherwise, and capture the tissue. This kind of biopsy would not pick up your cancer. Only this targeted biopsy will pick up the cancer in the so-called transition zone. After we got all the tissue specimen, we got to send each specimen in each separate bottles, so we know later on which tissue contains prostate cancer. So we got to know exact location of your cancer within your prostate. And we
Dr. Bahn?
Yeah.
I would like to ask you, I noticed that it says on the slide rectal end inked. So are you marking which end is it the tissue from, so later on you know if there is a penetration of the capsule?
For example, let's say as you see that this one marked as a right base, and we put the blue ink towards the rectal end of the tissue, that you will see that the black arrow already on the this picture. And then and we put the little blue ink towards the rectal end. So for example, if we found a cancer in the right base, then our pathologist is going to tell me whether or not your cancer is towards the rectal end or none, the other side of the rectal end. If your cancer is towards the rectal end, it is peripheral zone tumor. The cancer is at the other end, is a transition zone tumor. It is so important because there is a difference in biological behavior. So if someone is trying to have, considering active surveillance, of course we would like to see that you have a transition zone tumor rather than peripheral zone tumor in general, but we'll talk about in the future. And then if you have a cancer in the base of the tumor, then what is the problem? It is possible to invade to the seminal vesicle early on, and also invading into the superior neurovascular bundle, or easy to break the wall and invade the rectum directly. I'm going to show you a couple of the examples of the base tumor. Mr. CW, 68-year-old man, had a PSA4, glycine grade 6, and T1C. It's by random biopsy. So by definition, he has a very low risk disease. So his doctor, rightfully so, recommended him to have radical surgery because he has a small volume cancer. But if he doesn't want it, he couldn't even stay on active surveillance because of the all the informations are that he has an early low-grade disease. So he came to me. As you see that in the black and white study, there's a dark spot along the right side of the base, show that the fairly large volume, dark area. Color Doppler shows that dark area gets quite a blood flow. So it is quite suspicious that it is indeed his cancer site. And take a look at the next slide, that is side view, shows that the base level of the prostate again shows that a dark spot as we have seen, and then the dark spot gets increased blood flow, but it is awfully close to the seminal vesicle. So we end up with having a repeat biopsy, confirm that it is not glycine 6, it's a glycine 7, right base cancer, and also cancer was invading the right seminal vesicle. So his stage is now up to T3B. It's up from T1C. That means presumed to be a very low-risk disease, and now it is proven to be a high-risk disease. So definitely, in my opinion, he is not a candidate for an active surveillance, and he has to think about more aggressive therapy, and even a radical surgery could be some problem because of the known seminal vesicle invasion.